of what we have in the treatment and prevention toolkits as shown metaphorically on these toolkits here, from the numerous treatments that have been developed over the last couple of decades, as well as highly effective prevention modalities. And even among those that have been very successful, we are even already doing better. For example, many of us, myself included, who were taking care of patients when we first started getting antiretroviral drugs, the regimens were complex, some of them were suboptimal with regard to potency, and there was considerable drug toxicity. Today, as we all know, the dosage regimens are simplified, high level of potency, minimal drug toxicity, and many of them deliverable in one pill per day. This has led to a total transformation in the life expectancy of HIV-infected individuals, where early on in the 1980s, the projected life expectancy was about a year, 2 at the most. Today, if a 20-year-old comes into clinic, recently infected with HIV, and is put on the combination of therapies, and as I mentioned, often in a single pill, one could project that they would have an additional 50 years of life expectancy, which would put them almost, not quite, but almost within a normal lifespan. This has led to enormous positive returns of antiretroviral therapy. In the 20 years from 1995 through 2015, the delivery of ART has averted almost 10 million deaths and almost 8 million HIV infections worldwide, with economic benefits over $1 trillion. In fact, it's estimated that for every dollar that we've spent on antiretroviral therapy, we've had $3.50 in benefits. This has led to a substantial reduction in AIDS-related deaths. In the 13 years from 2005 to 2018, there has been a 55% reduction globally in AIDS-related deaths of all ages. However, what has really stood out has been the game-changing concepts in both treatment and prevention, where it was shown for the first time a very interesting phenomenon, that treatment actually does equal prevention in 2 major ways. Treatment as prevention, which this audience, I'm sure, is entirely familiar with, in which the iconic studies of HPTN 052 indicated that if an individual is started on antiretroviral therapy early, as opposed to waiting for the guideline trigger, that individual in a serodiscordant relationship has a more than a 95% diminution in the likelihood that they would transmit the virus to their uninfected partner. 5 years after that paper was published, the data remained stable. However, it was then realized that when you looked at viral load and looked at individuals who below detectable, there were no linked transmission among individuals in which the infected partner was below detectable level. Now, this was almost an unbelievable result because it was too good almost to be true. So what we did is we embarked on a number of important studies, particularly among men who have sex with men. And the studies were Partners, Opposites Attract, and Partners 2. And what we saw in observation of over 150,000 condomless sexual acts, that there was not a single linked transmission from an HIV-infected partner whose virus was below detectable level, which has then allowed us to say with confidence, as I expressed in a paper just a few months ago, that we now have the true scientific basis to say with confidence that undetectable truly equals untransmittable. Now, the other component of these game-changing concepts is pre-exposure prophylaxis. We now know from a number of studies that with high adherence, either to 1 pill a day or to PrEP on demand, that you have a more than 95% efficacy in preventing the acquisition of HIV infection in an uninfected individual. In fact, the results are so impressive that the United States Preventive Services Task Force examined in 29 studies involving 55,000 individuals that the recommendation was very strong, a grade A, to offer PrEP to anyone at high risk of HIV infection. Now, if you put those two things together, treatment as prevention with all of the benefits that I mentioned, together with pre-exposure prophylaxis, if you think about it for a moment, theoretically, if we accessed or put on antiretroviral therapy all or almost all people who are HIV infected and provide pre-exposure prophylaxis for all or almost all individuals at high risk for HIV, we could rapidly end the epidemic as an epidemiological phenomenon. It makes sense. If nobody is infecting anybody else and the people at risk are on PrEP, we should be able to do that. That's theoretical. However, we don't live in a theoretical world. We live in a real world, and it's our imperative and our challenge to bridge the gap between what is theoretically possible based on breathtaking scientific advances and what we can realistically accomplish in ending the HIV epidemic. But let's look at what is actually happening. We are not doing as well as we can, because if you look at the 18 years, the 8 years between 2010 and 2018 globally, there has been less than a 2% annual decrease in new HIV infections. Clearly, we need to do better than that. What are the implementation gaps in addressing HIV? It involves gaps in testing, treatment, retention and care, viral suppression, harm reduction, food and housing, human rights, including stigma. There are many things that need to be addressed. So let's take a look at the treatment and prevention implementation gaps in how we are addressing the HIV pandemic. First, the global treatment gap. The good news is that there are now 23.3 million people globally receiving antiretroviral therapy. The sobering and disturbing news is that there are almost 15 million people who should be on therapy who are not on therapy. What about retention in HIV treatment? The average retention in low and middle income countries over a 48-month period has dramatically diminished from the initial 100% down to about 60%. Clearly, we need to do better than that. What about the utilization of PrEP? We know it works. In the 2020 UN targets, there should be 3 million people globally receiving PrEP. And yet, as of a couple of months ago, only 475,000 are on PrEP. 63 countries have PrEP programs, but 130 countries don't. Clearly, we need to do better than that. So how do we optimize this? How do we optimize the way we can get to the end game of ending the epidemic? There are two major avenues of approach. The first is to maximize the implementation of the tools we already have. Can this be done? We have some interesting and I think compelling examples in the United States, but we're not alone. Others in other countries are doing the same thing. Probably the best example is San Francisco in their Treat All and Rapid HIV treatment, in which they proactively go into the community, seek out people, test. If you're infected, you're on therapy. If you're a risk and you're not on any prevention, put you on PrEP. What has resulted from that? A dramatic decrease in new diagnoses in San Francisco. When New York heard about San Francisco, they decided they'd like to do the same thing. And Governor Cuomo instituted a San Francisco-like approach in New York. What happened in New York? The new HIV diagnoses went down dramatically. I had the personal experience and honor of working with colleagues in the District of Columbia, the Department of Health with the help of the mayor, together with the CFAR in the Washington, D.C., and the Washington Hospital Center, and the District of Columbia, for those of you who don't know it, had the highest prevalence and incidence of HIV infected in the entire United States. So what happened when we tried to optimize? The new diagnosis dramatically went down. These are just some examples of what can be accomplished. Now, what about the development of new tools, things that we don't currently have? There are two components of new tools. The first is new treatment tools. What are they? One would be optimizing the treatment by durable control of virus without the need of daily ART. Adherence data tell us we must go in that direction. One of the ways to do that is very aspirational, not impossible, but aspirational, and that is true eradication of the virus. These are some of the approaches that have been used over the last several years. Some of them have resulted in a very rare success, such as stem cell transplantation with a delta 32 CCR5. There have been only 2 cures, with a third still in just a few months following the procedure. But the Berlin patient and the London patient, which are now well reported as shown in these patients, had a procedure that is not scalable and not good and not doable for the 37, 38 million people who are living with HIV. So one of the approaches is perhaps we can gene edit out the CCR5. As a matter of fact, this is being attempted, but a caveat paper has just appeared that when you look, as they did in England, of over 400,000 individuals who were naturally born homozygous for delta 32, there was a 21% increase in all-cause mortality. So we need to be careful when we start manipulating the genes, the natural genes of an individual. What is another way that conceptually might actually be safer? And that is using editing out of the HIV provirus with CRISPR-Cas9, using the guide RNA to localize the provirus and the Cas9 to clip it out. There are some rather encouraging data from 2 animal models that have recently been published, one in a non-human primate and one in a subset of humanized mice infected with HIV. These are still early preclinical, but at least tells us a little bit about the feasibility of such an approach. Now, antiretroviral therapy, long-acting, is another goal that we need to pursue. Again, because adherence of daily ART, more so in some regions of the world than others, could be problematic. There are a number of studies, 2 reported here just a few months ago in Seattle at the CROI meeting, of once-monthly injectable carbotegravir, which is a long-acting antiretroviral, together with rilpivirine, which show that you can actually maintain the suppression of virus with a long-acting injectable. There's another new interesting approach called broadly neutralizing antibodies. We know now we've isolated and characterized over 200 broadly neutralizing antibodies from people who were naturally infected and developed broadly neutralizing antibodies. A number of these shown on this slide are now prepared for clinical development by GMP preparation. And in fact, there have been a number of studies that are marching in the direction of using this intervention. One of them shown here was a study that I and my colleagues, together with colleagues from the University of Pennsylvania, were involved in, which we passively transferred one antibody, VRC01, and showed that when you stop ART, it clearly delays the rebound of virus. Others have gone one step further, using a combination of two. In this case, studies from Michelle Nutzenzweig using 3-BNC117 and 10-1074, which showed that when you passive transfer antibody, do an analytical treatment interruption, you delay the rebound for a considerable period of time. In fact, you now have one antibody against 3 epitopes. We refer to that as a tri-specific antibody that was started in clinical trial 4 months ago in April of 2019. So as you can see, there's a lot of activity to try and optimize this approach. And then we have the anti-CD4 antibodies. One has already been approved for salvage therapy, ibilizumab, and another which is along the line of suppressing rebound when you stop therapy. What's the ultimate goal, the ultimate end game? To have something, whatever, that you can give about every 6 months or even longer, perhaps every year, of passive transfer of a combination of antibodies that would ultimately replace the problematic need of having daily antiretroviral therapy. So let's move on to prevention. We can optimize prevention in 2 important areas. One is pre-exposure prophylaxis. So how can we optimize that? We know, and this is a very important study that was discussed at this meeting, 4 separate studies, treatment as prevention, PopArt, SEARCH, and YATSE, have shown that even with effective, aggressive treatment as prevention, although it is a necessary component of anything we do, with one small exception, showed significant decrease in incidence. All the others a slight but not significant decrease, which is telling us, I believe very strongly, that PrEP together with treatment as prevention may be needed if we really want to dramatically decrease incidence, which equals control, which equals end of the epidemic. Be careful that we don't interpret this that treatment as prevention is not critical, because it truly is as part of the combination. So how do you optimize PrEP? You have short and long-acting pills, long-acting injectables, and even implants, which you'll hear about, monoclonal antibodies, topically applied, and multiple purpose tools together with contraception. Let's take one of these, long-acting PrEP. One is an ART-based long-acting PrEP. In other words, get an antiretroviral and inject it the same way as we did in the treatment protocol. And there are a couple of studies, 2 randomized controlled trials of long-acting cabotegravir versus oral Truvada in men who have sex with men and transgender women, and another study, very similar, in women in sub-Saharan Africa. In fact, there's one that you're going to hear more about at this meeting in an injectable form, MK8591, which has been now in a formulation in a rhesus model of 1 pill a month of oral PrEP instead of injectable PrEP. The implant, which may be game-changing, you'll be hearing about soon. Now let's move over to what can we do to optimize broadly neutralizing antibodies. So here's the scheme again of broadly neutralizing antibodies. Those antibodies, besides being used as a tool themselves, also can be used in a way that you can optimize by making them long-acting. And you do that by a very simple mutation in the Fc portion of the antibody, as shown in this study in a macaque model by Malcolm Martin, in which he had 4 to 6 months of protection with a single transfer passively of broadly neutralizing antibodies. the 3BNC117 and the 101074. In fact, passive transfer of antibody is involved in an already fully enrolled trial in Southern Africa and in North and South America. Hopefully, a success of that trial will prove the concept that you could use it as an intervention, but it also says that if you induce it with a vaccine, you may be able to prevent infection. And then finally, vaccines, a great aspirational goal for all of us in HIV. Now, I've been talking for a long time that we now have the tools, if we implement them properly, to end the epidemic. I don't want anybody to get confused in thinking that I don't think that we really do need an HIV vaccine if we want to durably control the outbreak throughout the world, in every region of the world. And that's why I wrote this article a few years ago in saying that an HIV vaccine is essential for ending the epidemic. So we have two pathways to a vaccine, among others. The first is to empirically test a number of products the way we do with other types of viruses, find one that works, and then optimize the correlate. After many failures, we had one success years ago, modest, the now famous RV144 trial from Thailand, which was 31% effective among 16,000 people in the trial. The Kaplan-Meier is shown here. It was not ready for prime time, so we didn't deploy it. But it was the first signal upon which we were able to develop immune correlates. And to our surprise, they were not neutralizing antibodies. They were non-neutralizing antibodies against the V2 epitope, which was not an epitope that we would have predicted. So what are we going to do with that? We're going to amplify that by increasing the strength, the breadth, and the durability. How do you do that? Multiple boost, modified vectors, adjuvants, and mosaic antigens. And in fact, there are 3 trials that are going exactly in that direction. Let's take a look quickly at each of those. The HVTN 702 Uwambo, which is taking place now in South Africa, it was launched in November of 2016. It very closely resembles the RV144. It's a poxvirus vector followed by a boost with an adjuvant added. It's fully enrolled. We should have some results by 2021. Then there's the Imbokodo, which is taking place in multiple countries in Southern Africa. Again, it's fully enrolled, but it's a little bit different concept because it's the use of an ADN26 vector, but the inserts are expressing mosaic antigens. Namely, instead of one strain, it's trying to cover the waterfront, followed by a clade C boost. And then another that you've heard announced at this meeting, Mosaico, which is similar to the other in that it's a quadrivalent Ad26 vectored mosaic, but the boost is also a mosaic. And as you can see from this map, this is taking place in Europe and in North and South America and should be launched in the 3rd quarter of this year, sometime in the late summer, early fall. But there's another area that's being approached that is being very actively pursued, and that is to assume a correlate of immunity and to design your vaccine to induce that correlate. So what's the most obvious assumption? One that's worked for almost every single virus to which we successfully developed a vaccine. Namely, assume that broadly neutralizing antibodies that you would induce with a vaccine would afford protection against an acquisition of HIV. So let's return to this slide again. We have a lot of broadly neutralizing antibodies, but instead of using the antibodies, we're asking them to identify what we call neutralizing epitopes, and there are several of them now that are being actively studied. The chore then would be take one or more of those epitopes and turn them into an immunogen that could be used as a vaccine. And there are now a number of approaches and a collaboration called CHIP, or the Collaborative HIV Immune Project, has been established at NIH founded on the two Chavi programs on the East and West Coast, but inviting anybody involved in trying to induce broadly neutralizing antibodies to join the collaboration. And it's based on 3 approaches, and I'll very briefly describe. One is the lineage-based approach, what we call germline targeting. So let me go through it in a schematic way to explain it. We already know we have well-characterized broadly neutralizing antibodies. So the first step, we're already there. What do? You get the genetic sequences of those antibodies and you trace them back to what the B-cell precursor was that made that antibody. That B-cell precursor is called an unmutated common ancestor. So you find that. Then what do? You design an immunogen to prime the immune system. And then with a series of boosts, which are now being studied in animals, you get right back to where you started from with the broadly neutralizing antibody. Now, is this pie in the sky, or are we actually doing that? Well, we are. These are 4 of many studies that have been using this in a mouse model in which they've actually used B-cell lineage design to induce and engage the germline B-cell. We've now made it into humans. And in October of last year, a phase 1 trial study was done and reported in Science using this very approach. The next approach is what we call epitope-based vaccine design. How do you do that? Well, you now, since we have very good structural-based vaccine design, you analyze and characterize those epitopes that I mentioned to you. You look at those and you use them as immunogens. But how you do it is you congregate multiple antibodies. So on the left side of the slide are 3 antibodies against 1 small epitope, and that happens to be called fusion peptide. It could be any other epitope, but in this case it was the fusion peptide. You then find the precise structure, you scaffold it, you make it into a vaccine, and then you induce broadly neutralizing antibodies. This has actually been done and reported in Nature Medicine, in which fusion peptide-directed antibodies were isolated from immunized mice, and they already started to have a breadth of protection, about 31% of all strains. And then finally, there's using the native trimer, but we're not going to use that as a prime. We're actually going to use it as a boost because it's very difficult to engage the germline with the unmutated envelope itself. So there are about 8 good studies, maybe 10 or more, over the years that have shown the proper conformation of the native GP120 envelope native trimer. So how are you going to approach that? I already showed you the epitope-based, where you identify with antibodies, get the peptides, scaffold them, and make a vaccine. Well, now what we're going to do is we're going to use that as a prime and then come in with the full trimer as a boost. This is something that is being very actively pursued now, and hopefully in a year we'll have data. So having told you all of that, how good is good enough for a vaccine? I get asked that question all the time. I already told you that 31% was not ready for prime time. We're not going to deploy a 31% effective vaccine. Are we going to get a 95% effective vaccine? I really doubt it. I don't think we're going to get a measles or a polio-like vaccine. But we're striving for something about 50 to 60% acceptable, because together with the non-vaccine approaches for prevention, I think those 2 things together could have a major impact. In fact, if you model that, as Alison Galvani has recently done, and say, if you don't change anything, you don't even accelerate the things that I've been saying, but you look at the status quo and you insert into that a vaccine that's 50% effective, not 95% effective, 50% effective, you could have a major impact on the kinetics of the vaccine. And so, finally, in conclusion, we now have a number of eloquent tools in both treatment as prevention, as we discussed. We have two major ways of getting us to the end game of where we want to be. Maximize the implementation of the eloquent tools that we already have, and do our scientific innovation to develop new treatment and prevention tools to ultimately use them together in synergy to end the global HIV pandemic as we know it today. Thank you.
Well, thanks so much, Dr. Fauci. It's always wonderful to hear the updates from you and your extraordinary ability to convey a lot of complex science for us all. We now have, in this special session, a special event, which is that two extraordinary scientists, Nora Volkow, who I'll introduce in a moment, and Patricia Volkow, also happen to be sisters, and this is the first time that they've ever appeared on a scientific stage together. So I think that really is something very special. Dr. Nora Volkow, who I'll introduce first, many will know in this audience, she is the director of our U.S. National Institute on Drug Abuse. And over the past 30 years has really been an extremely important and productive scientist in her own right in the areas of substance use and the brain. She's published more than 770 articles and more than 95 book chapters, edited 4 books on brain imaging and addiction, which is her particular specialty, and co-edited an encyclopedia on neuroscience. She's the recipient of many awards, including the International Prize for Science from the French Institute of Health and Medical Research. Time magazine named her one of the top 100 people who shape our world. Newsweek as one of the 20 people to watch, and U.S. News and World Report as an Innovator of the Year. Her work has been instrumental in transforming the paradigm of drug addiction from that of a behavioral choice to that of a treatable brain disease. So please join me in welcoming Dr. Nora Volkow.
Good afternoon. Buenas tardes a todos. It's a pleasure to be here with you. I actually thank the IAS for having invited me. And it's a privilege, of course, to be here with my colleague, Dr. Tony Fauci. And it's also a privilege to be here with my sister, Patricia Volkow, who has been devoting her life to treating patients with HIV. I am working with substance use disorders, and I came to HIV because this is one of the consequences. She came through drug use because among people with HIV, many of them got infected through the use of drugs. And in fact, we do know, and we have known for a long period of time, that drugs have played a role in the infections from HIV. In particular, injection drug use is associated with a much higher risk of infections of all types, including hepatitis C and HIV. The contribution overall currently of injection drug use to new cases of HIV is approximately 10%. However, this varies geographically, and in some countries the contribution is very high, as is the case of Russia or Brazil. Now, as mentioned by Dr. Fauci, there has been globally a decrease in the new cases of HIV. However, this has not been the case for injection drug users, where in fact the incidence of HIV is increasing. And I think that this is something that we need to pay special attention, because it should target our efforts to not neglect these populations. Now, what happens in the United States? And in the United States also, we had seen significant decreases for many years of the incidence of HIV among injection drug users. However, this may be changing. And what is bringing this change? Well, the opioid crisis. The opioid crisis in America has been devastating, and it has been predominantly driven, the devastation has been predominantly identified because of the enormous amount of people dying from overdoses. So in 2017, for example, there were more than 70,000 individuals dying from an overdose. And you can also see how rapidly the numbers of deaths have escalated and how they have distributed throughout the whole United States. The maps that you're seeing there are overdose mortalities per 100,000 individuals. And you see from 1999 to 2016, a dramatic rise in deaths. However, the opioid crisis has also brought about a significant increase in injection drug users. And you can see from data that has not been published that between 2002 and 2017, the number of heroin injection drug users in the United States has tripled. So what are the consequences of this increase in injection drug use with respect to infections? And it is clearly recognized that this increase in injection drug practices has been associated with an extremely fast increase in the incidence of hepatitis C. So what are the consequences with respect to the incidence of HIV? And I cannot say that this increase in injection drug use among heroin users has resulted in the United States on an increase in HIV. And I cannot say that because we do not have, as of now, current centralized data that is recent of 17 and 2018 or 2019 of the new cases of HIV among injection drug use. However, what we are very aware is that there have been outbreaks of HIV among the counties that are badly affected by the opioid crisis. The most notable of them was Scott County, Indiana. That resulted in 215 cases, HIV cases, from injection drug use in 2014 and 2015. And this, by the way, was due to the fact that they did not have needle syringe exchange programs. This should have not happened. And what we are observing now, and these are reports that I actually was able to dig out of newspapers, so the accuracy of it is probably not precise, but it's also likely to be an underestimation. You can see across many of the counties, some of them corresponding to counties that the CDC had identified as being at high risk for an outbreak of HIV, such as what we're observing in Philadelphia, Northern Kentucky, or West Virginia. But others are appearing in counties that the CDC had not identified. And the risk for identification of those that are at greater risk are the number of injection drug users? Do they have needle and syringe exchange programs? Do you have treatment for individuals with opioid use disorders? So why this behavior? Over many years of research, we have come to understand clearly that drug addiction is a disease of the brain. We have also come to understand that it disrupts multiple circuits that are fundamental for everyday choices. In the person that's addicted, for example, there is a significant downregulation of the systems in the brain that enable us to perceive rewards and motivate our actions. As a result of that, people that are addicted actually seek that drug because it's the only stimulus that can activate it. In parallel, as you can see in the lower part, the left corner, there is a downregulation, dysfunction of the prefrontal areas of our brains, which are necessary for self-regulation and control, which explains why people who are addicted, even though they don't want to take the drug and they recognize its negative consequences, cannot inhibit the strong desires to take them. So what do we do? Well, addiction is a disease of the brain, but it can be treated. And we're very fortunate in the case of opioid addiction that we have 3 different classes of medications that are very effective in treating individuals with an opioid use disorder or opioid addiction. I'm going to be using terms interchangeably. There are 3 different classes. The oldest one is methadone. And this is a drug that, like the other 2, binds to the same target that binds heroin, the mu-opioid receptor. And when it binds it, it's basically described as a full agonist because it produces maximal intracellular signaling cascade. This is a drug that requires daily dosing. The second type of drug is buprenorphine. It is described as a partial agonist at the mu-opioid receptor because even though it has a very high affinity to bind to this receptor, the intracellular signaling that it engenders is 50 to 40% smaller than that produced by a full agonist. And this is a drug that can be given depending daily or on an extended release formulation. And finally, naltrexone is an antagonist for the mu-opioid receptor. It binds with very high affinity to that receptor, but it produces no intracellular signaling cascade. And thus, it prevents any pharmacological effects of any opioid agonist. These medications, the 3 of them, have been shown to be highly effective on a wide variety of parameters. They decrease drug use. They basically prevent overdoses. You are 2 to 3 times less likely to die of an overdose if you are on a medication than if you are not. And they significantly improve outcomes on infectious diseases. And that includes they prevent HIV, they prevent HCV, and they improve the overall outcomes of those in people that are infected. So to the right, you see a meta-analysis actually that was done in different continents that actually shows the effects of medications for opioid use disorders, these 3, buprenorphine, methadone, or naltrexone, in reducing HIV infections by 54%. And so medication for opioid use disorder is also a prevention for infection because it's preventing you from injecting drugs. And this data also shows its effects when someone already has HIV and is addicted to opioids and is given the medications for opioid use disorder. It significantly increases the likelihoods that they will be on antiretroviral therapy. It increases 2-fold the adherence on antiretroviral therapy, and it increases by 45% the odds of plasma viral suppression. So we have very powerful tools to actually help those individuals that are addicted to opioid use disorders. And this is fundamental too, because if you want, as was presented eloquently earlier by Dr. Fauci, if we want to retain people on antiretroviral therapy, if they are addicted to opioids, the way that we're going to succeed is by treating them with a medication for their opioid addiction. Otherwise, the risk of discontinuing the antiretroviral therapy is extremely high. So, if we have these tools, why not apply it? And there is, of course, always the academic theoretical concept and then the reality of what we are facing. And you see geographically, what you see in that map is that different countries, in terms of whether the extent to which they have access to these medications for the treatment of opioid addiction. In purple are the countries that provide those medications, and in gray are the countries that do not provide these medications. And what is striking is how many countries are in gray, despite the fact that the evidence shows that these medications are very effective. Now, the United States, which is in the middle of the purples, which actually provides medications for opioid use disorders, not completely. There are many patients that don't have access to it, but nonetheless, there are many places where they can get treated. If you extrapolate that into the cascade of care, like you do for the HIV, you can see that in the United States, the gap between what we want to achieve for the person that's addiction, that is initiate them, screen them, diagnose them, initiate them on medication, retain them in medications, and lead them to recovery. There's a horrific gap there. So our challenge is how do we make this possible? Now, again, you are trying to change a culture on the one hand and to provide an infrastructure that will enable you to do that. In this respect, one of the strategies has been, and in the United States with the opioid crisis, it has rapidly been recognized that we do not have enough treatment programs, specialized treatment programs for addiction to take care of the enormous amounts of people that have become addicted to these opioids. But we need not rely on specialized treatments. There's no reason why we cannot use the healthcare system to screen and deliver treatment for individuals addicted to drugs. And now we know from multiple independent studies that when the healthcare system, and in this case I'm showing you data from primary care physicians, actually provide the buprenorphine to their patients with an opioid addiction, the outcomes are as good as those that you obtain when you are in a specialized treatment program. And this actually makes it much more sustainable. The other setting that we have to actually expand our ability to identify and treat people that are addicted to opioids with or without HIV is the prison and jail system. And we know that individuals that suffer from substance use disorders are much more likely to be incarcerated. And in no way do we condone incarceration of people because they are addicted. Addiction is a disease, it's not criminal behavior. But despite that, these individuals are much more likely to end up incarcerated. The prevalence of HIV in prisons and jails, at least in the United States, is 3 times higher than that in the community. And if you initiate treatment in the prison or the jail system with a medication for their opioid use disorders, you significantly improve their outcomes in terms of them being able to sustain the treatment and recover for their addiction, prevent them from dying, and you also improve their outcomes if they have HIV. And so I'm illustrating, I just chose a paper that was recently published in which they show the difference on sustaining viral suppression when the individual leaves the prison or jail, which usually improves their viral suppression because they are given medication, but once they are released, they lose it due to relapse, to drug taking, homelessness, and low linkage to care. Well, models of care, just as simple as this one, you initiate the medication, in this case, an extended release formulation of naltrexone, 1 week before the person leaves the prison or jail. 1 week before they leave it, and you follow them 6 months later, and you can see a very dramatic difference in outcome as opposed to just referring them to treatment. So medications work. But as it's the case for the HIV and the recognition that having to take a drug on a daily basis actually is not necessarily always makes the patients always compliant, the recognition that extended release formulations or long-acting formulations actually improve compliance has led us to focus our research in part to help develop formulations that will make it easier for patients to sustain treatment and not relapse. So there are treatments, extended release formulations for naltrexone, the antagonist, and there are treatments, extended release formulations for buprenorphine, once a week, once a month, every 6 months. And currently, researchers are working for an extended release formulation of methadone. These extended release formulations will also make it easier to reach difficult-to-reach populations like rural communities, and will make it also much more acceptable to the justice setting where there is fear that medications may be diverted. So yes, we have a lot of evidence. We do know that syringe and needle exchange programs are very effective in preventing HIV among injection drug users. We know that medications for opioid use disorders are very efficient in preventing HIV and improving actually viral suppression, which in turn will lead to actually decreasing infectivity. We also know that treating with antiretroviral therapy, regardless of CD4 count, can lead to viral suppression, will be prevention against HIV. And we need to implement it. But if we ask ourselves the question, how do we prevent substance use disorders? I think that we need to turn into socioeconomical factors that we have to address. And I decided to finish my talk with this picture. It's a picture that you don't see in a scientific paper, but I think it tells us a very powerful story. And this picture, which was taken recently as part of the opioid crisis, attracted my attention not just because of the harshness of the environment, but because of the loneliness and isolation of this individual. And it is that loneliness and isolation and the lack of alternatives and possibility of change that perpetuates the use of drugs, that makes people vulnerable for drug taking. Now, how important are those social factors? And I'm using an extremely simple experiment that gives you an incline of how relevant they are. This is a study in which basically, like many others, uses rodent models, rats, in order to investigate the extent to which they will be administered different types of drugs of abuse, and rats actually administer drugs. In this case, they trained the rats to press a lever in order to get heroin, and the rats readily press the lever to get heroin. But then the investigator changed the equation. Instead of only giving them one lever to press and get heroin, they gave the rats a choice. They could either press the lever and get heroin, or they could press the lever and get the opportunity to have a social contact with another rat. And when the rats had a choice, they stopped taking heroin, and instead they pressed the lever that enabled them to have the social contact. So it prevented heroin administration. However, when the social contact was penalized, such that when the animal pressed the lever and there was an electric shock delivered before the animal had the chance to interact with the other rat, then heroin taking went up and social interactions were down. So the message here is that if we want to prevent substance use disorders, and if we want to improve the likelihood that people recover, our society has to provide a structure that will enable people to have minimal social interactions, to have opportunities, and to have choices. Thanks very much for your attention.
Well, thanks so much, Dr. Volkow, and now I get to introduce the second Dr. Volkow. Patricia Volkow is an infectious disease specialist here at the National Cancer Institute in Mexico City. In the late 80s, she described the impact of plasma and the blood trade on the HIV epidemic in Mexico, and in 1990, she started the AIDS Cancer Clinic to treat and investigate HIV-associated malignancies in the city. As a member of the Clinical Committee of the National Council to Fight AIDS, CONCIDA, and the Council to Fight AIDS of the Mexico City AIDS Program, she's participated in national guidelines to treat people living with HIV, and she's done work in clinical management and HIV-associated comorbidities, in the prevalence of HIV and other STIs in incarcerated people, and epidemiologic studies here with women living with HIV. So, Patricia Volkow, please.
I appreciate and I'm thankful to the organizers to allow me to talk about this topic that has taken my attention for the last 30 years. Kaposi sarcoma and pneumocystis pneumonia were the two markers of the initiation of the pandemic. In the United States, almost 30% of AIDS patients develop Kaposi sarcoma lesions before the era of antiretroviral therapy. Indeed, KS was recognized as a second epidemic. In 1994, Dr. Chang and collaborators identified an HIV virus, also named Kaposi sarcoma herpes virus, in all the cases and lesions of Kaposi sarcoma and in PBMCs. The scenario of Kaposi sarcoma in high-income countries with access to antiretroviral therapy has changed dramatically with a decrease in the incidence rate. But this is not the case for Africa. That is where is still the most frequent AIDS malignancy diagnosed in the area. The prevalence of infection with HIV/AIDS is high, particularly in Central African countries and East countries, up to 82% in Cameroon, in Uganda, almost 70% in women in prenatal clinics. The K incidence has increased to very high rates in the region because of the high co-infection of HIV and HIV/AIDS. The lesions, what we see in the lesions is angiogenesis, inflammation, and proliferation. Wells of spindle cells with leukocytes infiltration and aberrant proliferation of small vessels that lack basement membrane and have a leaky behavior, microhemorrhage and hemosiderin deposit. The disease involves the gastrointestinal tract, the lung, the lymph nodes, and produces massive lymphedema and pleural effusion. It has been considered an enigmatic, unpredictable disease with patients with an incidental lesion to fast, explosive, rapidly progressive disease. It produces a devastating physical and psychological disease, and when it involves the lung, it can produce as high as 40% mortality. The human herpes virus is a double-stranded DNA. If it infects B cells, monocytes, and endothelial cells. HIV/AIDS has a gene machinery that mimics human oncogenes, and this is very important in the pathogenesis of the disease. As all herpes virus, it has a latent phase and a lytic activity phase. In the latent phase, practically only one gene is expressed, producing a p53 protein that decreases apoptosis and increases survival of infected cells and evade host immune. But in the lytic phase, there is practically the expression of all the genes of the virus, promoting replication and release of progeny virions and death of cells. It promotes cell division of infected cells, inhibits apoptosis, modulates inflammation, induces angiogenesis, but does not produce immortalization, and it is considered a multicentric multiclonal disease. What are the factors that trigger the lytic phase of the virus? Mainly inflammatory cytokines like IL-6, oncostatin, TNF, PTGF, and DF, and the TAT protein of HIV. And this is given in a milieu of immunodeficiency. This is the first publication of the clinical characteristic of Kaposi sarcoma patients in 1982. And what I want to highlight is the high percentage of co-infections in this cohort. 7 of the patients had CMV disease, 5 of them have syphilis. There were besides gonorrhea, giardia, amoebiasis, toxoplasma. So these patients were heavily co-infected besides having Kaposi sarcoma. The European consensus based interdisciplinary guidelines for the treatment of Kaposi sarcoma divides this disease in good prognosis and poor prognosis disease. And for poor prognosis, you only need to give antiretroviral therapy, but for poor prognosis, that means extensive disease with highly immunodeficient patients with B symptoms, they recommend CART plus chemotherapy. And I want to highlight why they state that the goal of the systemic therapy is not to cure, but to achieve disease control and symptoms-free relief with quality of life preservations. And they present some of the clinical phase 3 trials with different drugs. And what I want to highlight is that progressive-free survival is of 12 months and of 129 days for pegylated doxorubicin. Here I present a study that we published where we have the overall survival in patients that were divided between those that developed IRIS and those that did not develop IRIS. And what I want to highlight is that the patient that developed IRIS, the mortality was present in the first 6 months after starting therapy, and afterwards, if the pass has the test, they will survive for long. 39% of this cohort develop IRIS-KS. And in this same paper, we presented that 66% of the patients achieved complete remission, half of them only with CART, and the other half with CART and chemotherapy. These patients were only receiving bleomycin and vincristine. Dr. Aldrich, in 2010, presented a very important paper, at least for me, and it was very important, to see how the HHV viral load was associated to the severity of the HHV diseases. And you can see that the severity of KS was significantly higher than viral load compared to mild disease. So then I asked myself the question, what is the role of ganciclovir in KS? We knew in the early years of the epidemic that ganciclovir was active in vitro against HHV8. And we also knew that ganciclovir reduced the risk of KS in patients that were receiving ganciclovir as secondary prophylaxis. Recently, they published that ganciclovir reduces oropharyngeal HIV replication. So though we hypothesize that ganciclovir's prodrug or the prodrug valganciclovir will be of therapeutically beneficial in the treatment of KS. And we did an open-label randomized clinical trial starting with 2 groups, the experimental group and the control group. And the experimental group started 4 weeks before starting CART with valganciclovir and all over the 48 weeks, and the control week only received CART. Chemotherapy with vincristine and bleomycin was initially given if there was extensive compromise or oropharyngeal lesions, and during the follow-up in cases of severe iris KS, or if the patient continued with extensive disease without iris. And this is the timeline of the study, the visits, and in each visit, we took an HIV, HIV-8, CMV, and EBV viral load, as well as CD4 count and CD8, and we also measure IL-6, IL-10, TNF, and EFN. We also took clinical pictures in every clinical visit, and we repeated HB, hepatitis B and syphilis serology on week 24 and 28. In the clinical evaluation and enrollment, I want here to highlight that we really make an aggressive workup study to diagnose co-infections. And this involves also, between all the studies, bone marrow culture and bone biopsy. And we also culture lymph nodes in cases of lymph enlargement. The inclusion criteria were naive patients with disseminated Kaposi sarcoma. That means that had pulmonary disease and or more than 30 lesions and or lymphedema and or lymph involvement and or gastrointestinal tract with biopsy proven only in one site, provided signed confirmed. The exclusion criteria were patients with another malignancy, Castleman disease, patient that had received steroids 2 months prior to screening, active hepatitis B and C, and organ disease, and Apache over 15. We screened 91 patients, and we finally fulfilled 40 patients with inclusion criteria. You can see the causes of exclusion. One patient abandoned, and another died 3 days after enrollment. So we finished with 90 patients in each group. For non-severe iris KS is the traditional criteria, and we stated a new criteria for severe iris KS. And this was the abrupt clinical deterioration after starting heart, at least two of the following: fever with no documented infection, abrupt increase in the size or number of KS lesions, and exacerbation of lymphedema, or increase in otherwise unexplained lung opacities on the chest X-ray, gallium negative, and abrupt appearance of at least of these 3 parameters: thrombocytopenia, less than 100,000, anemia, hyponatremia, and hypoalbuminemia. And I know it's a big table, but I just want to highlight that 75% of the patients were co-infected. We had 7 patients with histoplasma, 4 with MAC, and 10 with syphilis. And at least they have 1 herpes virus infection, and this was a replicating herpes virus infection. That means CMV, EBV, or HIV-8. The median CD4 count of the cohort was 69. They were very seriously ill patients. And here I show the Kaplan-Meier survival of the control group and the experimental group. In the control group, we had 3 patients that died with severe iris. And in the control group, no patient died because of severe iris. We have a patient that died because of an opioid overdose, and we had a patient that died with H1N1 flu. And here I show you the behavior of the viral load and CD4 of the control group and an experimental group. In the upper part, you can see that the patient arrived with very high HHA viral load and HIV viral load, and he was started on CART. The same day, we gave him a vincristine and bleomycin cycle, and the HHA viral load decreased, and HIV started to decrease, but then HIV-8 rebound, and CD4 count again decreased. This patient had unmasked pulmonary KS, and he died after 4 cycles of bleomycin, vincristine on the week number 10. In the low part of the slide, you can see a patient with an experimental group. He had a high HIV viral load, high HIV viral load. He was started on valsiclovir, and HHV8 diminished a bit, stayed stable. We started him on heart, and then both viral loads decreased, and the CD4 started to increase. And this patient achieved a 70% remission on week 58. Here I show the slides of the patient with the control group. This patient developed pleural effusion and infiltrates, and he finally died on week 10. And this is the experimental patient. He had infiltrates since the very start of the study. This grew a little. He had only had a slight of coffee. He was only had a slight of coffee. He was all, by week 58, he was working. He was economically active. But because he had this cough, we gave him a last cycle of bleomycin vincristine, and you can see in 64 weeks the control. So we really think that 8 patients with disseminated Kaposi sarcoma should be thoroughly evaluated to investigate and treat co-infections. Measurement of HHV8 viral load should be a standard in the care of patients with disseminated Kaposi sarcoma. In patients with over 1,000 copies of HHV8, valganciclovir can be beneficial in decreasing iris severity and iris attributable mortality. So I want to highlight the findings of this study, and if we want to stop cytokines production that in turn activate RTA, that is the molecule that activates the lytic phase of the virus, we need to diagnose and treat infections. We further need to give an anti-HHA viral load to diminish the HIV viral load and its signaling with valganciclovir, or there are other drugs that can be useful. We need to give antiretroviral therapy to stop that production and restitute immune function. And the last, we need to stop spindle cell proliferation. And this has to be done through MTA agents. That means microtubular targeted agents like vincristine and Taxol and taxanes, because they don't myelosuppress, they only activate, they only halt the mitosis, so they stop the proliferation of spindle cells. This is the patient, one of the patients of the protocol, and I do believe that we integrate all the knowledge about KS pathogenesis, we will be really able to change the prognosis of these patients.
Thank you very much, Patricia. It now gives me great pleasure to call on stage Dr. Michaela Muller-Trutwin, and this is in relation to the ANRS Dominique Dormont Prize, which is an annual prize. Dr. Michaela Muller-Trutwin studied biology at the University in Bonn and Frankfurt, Germany. She obtained a PhD from Paris University, France, in the Beyrer lab. She worked at research institutes in West and Central Africa and collaborated with the Institut Pasteur in Southeast Asia. In 2009, she obtained the position of Associate Professor at the Institut Pasteur. In 2014, she was appointed head of the unit HIV Inflammation and Persistence. She currently serves as chair of the National Coordinated Action on HIV Basic Research at the ANRS and as vice president of the Scientific Council at Institut Pasteur. Her research contributed to the discovery of several HIV and CIV viruses, such as the first CIV from African green monkeys in Central Africa and the first CIV from chimpanzees in Cameroon, as well as the demonstration of the expansion of HIV-1 subtype A in Central African Republic at the expense of other HIV-1 subtypes. Let's welcome Michaela Muller-Trutwin.
Thank you very much, Quarraisha. So it is a privilege to present the Dominique Dormont Award. I'm standing here on behalf of the IAS, the ANRS, and the Dominique Dormont Association. The award highlights the excellent work of a young investigator working on chronic conditions in humans with a particular focus on the interface of HIV and other chronic diseases. The prize is sponsored by the Dominique Dormont Association and designated to support the research of the candidate. The prize has been created in memory of Dominique Dormont. Dominique Dormont was internationally acclaimed for his work on prion disease and also for his very early commitment to HIV research. He was the PI of one of the very first antiretroviral trials. And from the beginning, he was a strong advocate of translational and multidisciplinary science. He was also a pioneer in developing the SIV non-human primate model. And in fact, he taught the whole generation in France on the macaque model, including myself. In his career, which was too short, he died at the age of 54. He had time to publish 400 publications. If the prize was created, though, it is to keep in memory his devotion for science to the benefit of humankind as an example for the young generation. And I think all who knew Dominique Dormont knew that he was a very modest person, and he would not have appreciated at all to be honored in public as we do today. This year, the award aims to honor studies in the fields of HIV cure, inflammation, and neurologic disorders. The study with which selected deals with persistent inflammation and epithelial damage in the gut, which generally persists in people living with HIV despite well-controlled viremia under ART. There is indeed a need for better and more specific markers of such damage in the gut. The award goes to Stéphane Inard from the Routy Lab in Montreal, Canada, for his remarkable work on the relevance of REC3 alpha in microbial translocation, inflammation, and reservoir size in people living with HIV. And if you want to hear more, you can go to the mucosal session tomorrow, Tuesday at 1 p.m. And it's my pleasure to congratulate Stéphane Inard.
Congratulations, Stéphane, and it just remains for me to thank all of our speakers for their outstanding talks. Thank you for your attendance.